very much. It is truly a pleasure to be here today. And what I'd like to do is talk about some osseous lesions that are typically found incidentally on imaging studies, and specifically address when to worry about these. And what I'd like you to be able to do at the completion of this section is recognize the common incidental MSK osseous lesions that can sometimes mimic more sinister disease, and be able to identify distinguishing features so you can say when you need to worry about them and when you don't. And the specific example is the 50-year-old that comes in with the incidental, quote, bone island, and your colleague says to you, well, could this be a blastic metastasis? How do you distinguish things such as that? And those lesions that I'd like to address are those listed here. The simple bone island, or enostosis, the Enchondroma, which we find now is really quite common, the subchondral cystic lesion, and the intraosseous lipoma, which we used to think is rare, but with MR we find is actually quite common. And let's begin with the enostosis. As I noted, it really is a very common lesion, and it's considered a hamartoma. That is, it's normal bone, in this case cortical bone, in an abnormal location that is within the intramedullary space. It's most frequent, as we know, in the pelvis, the ribs, and the femurs, and historically it's been estimated to be seen in about 1 to 4% of radiographs. The 1% comes from a study in 1964 where they looked at 5,000 cases and they found 42 bone islands. The 4% comes from a more recent study done by Resnick and colleagues where they looked at the cadaver specimens of 100 spines and found 14 bone islands, and then went back and looked at the radiographs and saw them about 4% that they could see on the radiographs prospectively. And it's probably somewhere in there. Those of us who do a lot of CT know that we really are very common, and we do see them very, very frequently. They're typically described as being round to oval, with radiating spicules or brush border, and as we'll see, that really is very characteristic and one of the features that we can see very nicely on virtually all imaging modalities. If we do a bone scan, they're typically normal or only minimally increased tracer accumulation. And very importantly, when we see them on MR imaging, they should image identical to cortical bone because they are cortical bone in a different location within the medullary canal, and so it should image identical to the cortex. And finally, something that we often forget about is they can change their size over time, becoming larger and occasionally even disappearing. They're composed of compact lamellar bone, typical of what we'd see in the cortex with an eversion system, and they blend imperceptibly to the adjacent trabecular bone, which gives them that brush-like or spiculated margin. And here we see a typical bone island, and if we look at the substance of the bone island itself, we can see that it is identical to cortical bone, and of course it blends imperceptibly to the adjacent cancellous/trabecular bone, giving it that spiculated or brush-like margin. And here, just to nicely show an example in the calcaneus that's pathologically proven, where we can see that bone island imaging identical to cortical bone on the radiograph with that little spiculated margin at its periphery. This a typical example of an enostosis or bone island. Here another example pathologically proven within the rib, nicely showing, in this case, an oval appearance. Again, more typically we see the long axis of the ovoid appearance along the long axis of the bone, and we can see some of that spiculated margin as well. We see it on every imaging modality, and here very nicely shown in this patient being followed for a fracture of the scaphoid, where we can see this bone island and the capitate very nicely showing the lesion with an attenuation identical to that of the cancer or the cortical bone for the substance of the bone island, and of course the spiculated margin nicely demonstrated on a high-quality CT. When we look at bone islands in the spine, they're often at the periphery of the vertebral body, sometimes adjacent and abutting the cortex, but the imaging appearance is the same as we see. And if we look at it on this T1 weighted image, again, no signal intensity, and very importantly on MR imaging, there should be no abnormal signal associated with it, particularly on T2 weighted images, no areas of high signal intensity. And again, we can see that spiculated margin, and although this is a noisy T2 weighted image, notice that the lesion images identical to the cortical bone on the T2 weighted image. And again here, showing just at its periphery that it may extend to the cortical surface, something that we do see in the spine not infrequently. This is a patient who had a history of prostate cancer and had this lesion biopsied in the supraacetabular area. It was biopsied when he presented initially. Here at 7-year follow-up, you can see the increase in size. And if you look through the literature, there really is no good guidelines for how much size is allowable for a change. Mira in his text notes that 25% at 6 months and 50% at 1 year. He has no justification given in that, but that's about the only I could find for any evaluation of change in size. And I take it all with a grain of salt. But certainly we do see size change. It usually is quite slowly, as shown here, over that 7-year interval. They can get smaller. There's no pathology on this particular case, but you can see the decrease in size. It's subtle, but I think it's quite real over this 4-year interval of observation. We can have giant bone islands. Giant bone islands are seen usually, that term given when they're greater than 2 centimeters in size, but here quite characteristic of the appearance. Notice the increased opacity similar to that of cortical bone without really changing or distorting the contour of the osseous structures, nicely seen on the sagittal T1 and the sagittal C2 image. And sometimes when they get quite large and seen like this, there can be some changes in the signal intensity and attenuation, although they're usually quite minor. Because of the large size and because it does take up tracer as cortical bone would, when they're very, very large, we can see some increased tracer accumulation as seen in this biopsy-proven bone island of the spine. And here, just probably the best example I've ever seen in a long bone signal intensity or attenuation similar to the cortex, no signal on T1 weighted images, axial CT beautifully showing that spiculated margin, and no abnormal signal associated with it on fluid sensitive sequences on that T2 weighted image on your right. Just a perfect imaging appearance for a giant bone island. Now there are some things to consider in the differential. Some of those are listed here. Polymethylmethacrylate, pneumatocysts, other fibroosseous lesions, and of course the one that we worry about is blastic metastases. And what I find most helpful is a sign described by Schweitzer a number of years ago, the halo sign, which is highly specific for metastatic disease and something we'll discuss in just a moment. This was read as a bone island, 6-year interval since the previous film shown on the right. Had the person who read it been a little more careful looking at the rest of the foot, he would have seen the arthrodesis of the first MTP, and that's certainly an area where they took cancellous bone graft for that surgery. And this just some barium impregnated methyl methacrylate filling the site for the bone graft. Here, a pneumatocyst within the sacrum, miscalled a bone island. Those are very observant. We notice a little susceptibility artifact in its inferior margin, but of course the diagnosis made on CT quite readily. And you might say nobody in their right mind would ever miss this for a blastic metastasis, but let me show you this case of a patient who was referred in for blastic metastasis of the spine, presenting with neck pain shortly after his diagnosis of prostate cancer. And of course, CT very nicely shows the extensive degenerative disease, and of course the pneumatocyst was mistaken as a bone metastasis. Now, not all things that are blastic are bone islands. Those of you who do a lot of musculoskeletal imaging will recognize this as an ossifying, non-ossifying fibroma, or perhaps better termed a sclerosing fibroxanthoma, and you'd appreciate the lobulated pattern at its periphery and the mild expansile remodeling of the cortex in this cortically based lesion, quite characteristic of it. And you'd also notice that it's really not completely homogeneous as you'd like to see for a bone island, but certainly the more distal aspect being more heterogeneous in its character. And it's quite characteristic of what we see in these healing or sclerosing fibroxanthomas or ossifying, non-ossifying fibromas. And here, just another case that came in not too long ago, made the diagnosis on the the original film, and I'm not sure why he was followed quite so adamantly. But here at a 2-month follow-up, you can see a little sclerosis, and when these heal by sclerosing or heal in, they virtually always start from the distal aspect, and that's a very characteristic feature of this disease process, this non-ossifying fibroma. As it heals, and you can start to see, and although they didn't follow him past 32 months, you can really see that lobulated contour and the sclerosis from the distal aspect of the lesion, highly characteristic of the pattern of sclerosis with this disease process. And of course, what we worry about is the blastic metastasis, and this patient recently diagnosed with prostate cancer with a single area of increased tracer accumulation on his bone scan, which was in fact a prostate metastasis proven by transpedicular biopsy. And how do you distinguish that from a bone island? Well, on imaging, it can be relatively easy sometimes. This is a patient that was recently diagnosed with prostate cancer, and this on CT during his initial exam was called a bone island. And you could say, well, it's not the classic appearance, but yeah, it looked pretty good. On MR done about a week later, you can see the lesion, and the first thing that should strike you is that on this fluid-sensitive sequence, it doesn't have the signal intensity of the dark cortical bone adjacent to it. Following the administration of contrast, you'll notice that there is a halo of increased enhancement surrounding the lesion. That's the halo sign that's been described in metastatic disease. This, nevertheless, was called the bone island, and they came back in at 4 months, and you can see the interval growth of this bone island, something that certainly could not be tolerated. And follow-up imaging with scintigraphy, which was normal 4 months before, now showed that lesion within his posterior ilium, as well as a second lesion within his lesser trochanter on the contralateral side. And of course, follow-up MR imaging beautifully shows on the fluid-sensitive sequence that halo sign nicely demonstrating everything to a better extent on the coronal stir imaging with that nice halo of abnormal signal, which will show significant enhancement following the administration of contrast. So that can be very useful in distinguishing a bone island from a metastasis. So when do I worry about bone islands? I worry when I see rapid growth. I worry when they're hot on bone scan, and when they don't image identical to cortex. And of course, if I see a positive halo sign, it's supposed to be reported at 75% specific and virtually 100% sensitive in identifying metastatic disease. And I will say I've used it over the years, and I've only had one false positive in a recent case, which we really just biopsied to death and still turned out negative. So it does fail occasionally, but it is, I think, a very useful sign. Next, let's take a look, or I should say before we move on, to emphasize enostosis, round to oval, spiculated margins we talked about. We talked about the signal intensities, and again, bone scan generally negative unless they're very large, and then they can show some increased uptake, although it's usually relatively mild. We'll move on to enchondroma. Enchondroma is a relatively common lesion. Jaffe, way back in the 40s in his text on bone tumors, noted that he postulated there were embryonic rests of cartilage from the physeal plate that were displaced into the metaphysis and evolved into dysplastic foci of cartilage separated by variable amounts of fat. And it's such an exquisite description because that's exactly what we see. And if you take a look at the gross appearance of an enchondroma, you can see the sparkling white hyaline cartilage separated by this normal marrow which extends between these lobules of cartilage. We see that pattern on MR so frequently. It's a very useful way to separate these enchondromas as a distinct lesion, and it's a very helpful diagnostic feature. We know they occur in boys and girls, men and women with about the same predilection, usually most typically seen in young adults, most common in the hands. And they may present as an incidental finding, and that's how we typically see it. When I was in the service, we saw them a lot, patients presenting with pathologic fractures after being in fights. Now we see them most often, at least in my practice, as incidental findings. On knee MR, it's been estimated about 3% will show an incidental enchondroma. And it's not just the knee. In a recent study about the shoulder, it was seen in 2% of MR images. So it's something that we do see with frequency, and we have to be able to identify. Pathologically, it's hyaline cartilage, as we talked about. It grows in lobules with varying amounts of enchondral ossification and calcification. The classic arcs and rings, stipules and floccules that we talk about as cartilaginous matrix. And here a typical enchondroma, this within a metacarpal. We can see the lesion well separated from the surrounding bone, and if we look at it at higher power, we can see the arcs and rings of enchondral ossification, as well as the floccules and stipules of mineralization that form the cartilaginous matrix. Radiographically, we know it's a geographic lytic lesion with variable margins depending upon the biological activity and the biomechanical forces across the bone in which the lesion is located, with variable amounts of matrix. Because the cartilage comes from the metaphysis or the physis, they're usually in the metaphysis and more typically central, although they can be at the extremities or eccentrically located within the metaphysis. And when we talk about them in the small bones, they can certainly have some mass effect. They can have it in the long bones as well, although when we see it in the long bones, we're more worried about an aggressive biological behavior. So I won't talk about it in the hands and feet, because those I think were pretty much straight on, and we'll concentrate it in the long bones. The image on your left was interpreted as normal, and I certainly don't see a lytic lesion, although retrospectively we certainly can see an area of sclerosis, which corresponded to the lesion seen on the right in this patient with prostate cancer who was being evaluated for metastatic disease on his initial presentation. And of course, we don't appreciate the lytic lesion there, remembering that we have to remove 30 to 50% of the bone present to recognize something as a lucency on radiographs, but we certainly can see the matrix produced by the lesion, which allows it to identify it. And of course, we can see the lesion. We can see the lobules of hyaline cartilage and, of course, some areas of matrix within it. I like this case particularly because on the T1 weighted image, you can see the lobules and you can see the fat going between the lobules within the interstices of the lesion. And there are very few lesions that have fat within them, because think about how bad things grow, how tumors grow. They start as a small area of cellular abnormality, and then they expand centripetally, pushing or displacing or removing the adjacent bone and filling it with tumor. And so there's really no fat within it. There's very, very few lesions. The only other lesion that typically will have fat within it occasionally is lymphoma, as it starts in multiple locations and extends through the bone. But typically it's much larger, much more extensive than that. And this pattern with fat within it is highly characteristic of cartilage tumors. And of course, on the right, you can see that septal and peripheral pattern of enhancement around these lobules of cartilage. Again, very characteristic of an enchondroma. When we see these cartilaginous rests, and we use that term for lesions that are less than 1 centimeter in diameter, again, very characteristic. If you'll notice on the T1 weighted image on your left, where you can see the fat within the interstices and extending between the lobules of the cartilage, and on the fluid sensitive sequence on the right, you can see the individual cartilage nodules with the fat extending between them. Highly characteristic of an enchondroma, or in this particular case, a cartilage rest. Again, if you like to use that term for lesions less than 1 centimeter. And notice that it's in the metaphysis right above the cartilaginous physis, where that cartilage theoretically originated from. Here, another enchondroma in the proximal humerus. Notice we can see that fat between the lobules extending on the T1 weighted image, and although not as apparent on the T2 weighted image on the right as well. We can see that lobular pattern of growth, very characteristic of cartilage, with the high signal intensity from the hyaline cartilage and the decreased areas of signal intensity or absent signal intensity from the mineralized matrix, or typically centrally, as shown in this case, in association with it. An enchondroma of the proximal humerus. When do I worry about cartilage lesions? I worry when, if we have a bone scan, there's marked radionuclide uptake greater than that of the superior iliac crest. I worry if there's deep or extensive endosteal scalloping, more than 2/3 the length of the lesion, or deep endosteal scalloping, more than 2/3 the thickness of the cortex. And this, of course, referring to long bone cartilage lesions. I worry when there's a change in the character of the cartilage matrix. If I have an old film, and I worry statistically if it's located in the epiphysis, in the classic study that looks at cartilage and malignant transformation. Of the 17 epiphyseal lesions, 15 were malignant. So we classically worry about them more when they're located in the epiphysis. Here, a cartilage lesion, beautiful cartilaginous matrix P1 weighted image, shows the lesion coming up and pressing against the cortex, but there was no endosteal scalloping. And the way I read it out, I would call it an enchondroma. If you prefer, you could call it a cartilaginous lesion with no evidence of an aggressive biological behavior, semicolon, most likely an enchondroma. And here the corresponding T2 weighted image. Nothing to worry about in that one. And we classically get a follow-up just to document stability, but we had a case not too long ago of a patient that we had 50 years of follow-up on of an enchondroma, and about the first 40 of those years it showed absolutely no change. Then it started to show some growth. It had not been characterized as worrisome for malignant, and he presented at about 90 years of age with a dedifferentiated chondrosarcoma. So you can't really follow it forever, but we do like to document growth, and that's just the oncologists I work with. But I always comment when there's no evidence of biological behavior. Here, a chondrosarcoma picked up on a DEXA study as an area of increased opacity in the proximal femur by a very alert radiologist and referred to us for this lesion. You can see the change in the cortex or in the pattern of mineralization. Unfortunately, there were no old films. This was a new finding. You can see the deep endosteal scalloping, the solid continuous periosteal new bone, all the features of a low-grade malignancy in this low-grade chondrosarcoma cured by en bloc resection. And here, another chondrosarcoma with areas of very deep endosteal scalloping in multiple locations, one shown here, as well as some periosteal new bone formation with this shell-like periosteal reaction overlying this area extending through the cortex. Low-grade chondrosarcoma, again, removed en bloc from the proximal humerus. So, common and more characteristics are highly characteristic, and chondrosarcoma typically shows much more aggressive features and should allow you to make that diagnosis with confidence. Subchondral cysts are also quite common. Sometimes termed intraosseous ganglia, geode, synovial cysts, subchondral pseudocysts, subarticular pseudocysts. None of those terms are really all that accurate in the sense that a cyst is a lesion that's fluid-filled in which the fluid is secreted or produced by the lining of it, and none of that happens with these degenerative lesions. But for what it's worth, that's the terms that have been accepted. More recently, it's been called a subchondral cyst-like lesion, and I kind of like that name, and I beat the fellows and residents into using it because, again, the initial terms are really not all that good to describe it. What we can say with confidence is that they're usually multiple, they're extremely common, they have variable cystic appearance, and we usually see them in older patients adjacent to certain joints, and they're typically associated with degenerative disease. For years we used to argue whether it's due to intrusion, that is intrusion of joint fluid into the bone due to some break in the cortex, or whether it was due to some contusion, that is a repair phenomenon secondary to injury to the bone. At the AFIP, and I worked there for a number of years when I was in the Army, the contusions concept was felt to be good, and the fact that there was some sort of an injury to the bone with focal fibrous proliferation, myxoid change, or sort of a proliferation of this myxoid change with secondary cyst formation from that, and that was the feeling there. And actually, more recently, that contusion theory with this repair has come into acceptance, and a very nice article in Radiology not too long ago really shows some beautiful examples of how that occurs. This from that article where they talked about these cyst-like areas, or I'm sorry, these areas of marrow edema within the bone, or I should say edema-like signal within the bone, and when they followed them over time, these were the areas of subchondral degenerative cyst-like change that appeared. And here a nice example that they showed of a patient that was followed for 30 months that had this edema-like signal within the bone. And I use the term edema-like because of this article that appeared back in 2000 in Radiology, in which they showed that, yeah, this was abnormal signal, but it included so much that there was marrow necrosis, necrotic or remodeled trabeculae, fibrosis, hemorrhage, and although edema was present, it was only about 4% of this abnormal signal. And so really, although edema, and this, again, I must emphasize, is in patients with osteoarthritic knees, at least in that case, this edema-like signal is due to a whole host of features. Edema, which is only a small constituent and not the major abnormal signal intensity cause. Anyway, but they did show over time that these areas, in this case now 30 months, did form these subchondral degenerative cysts. So really a nice study. Radiographically or radiologically, we know that they're typically associated with degenerative disease, classically adjacent to the articular surface, and they communicate, particularly at the towards the end or after they're longer standing, when there may be some disruption to the articular surface. Typically small, rounded lucencies, often with a sclerotic margin and a variable MR appearance. Here's the typical subchondral degenerative cyst. You can see it below the articular surface. And if we look at a histological example of what that would, or how it would occur, you can see that the normal fatty marrow was replaced by this fibrovascular tissue. If we highlight that area and look at it at greater power on the right, you can see that this fibrovascular tissue will undergo myxoid change, and these small microscopic-like cysts will congeal and combine to form these macrocystic areas with time, which can liquefy and become a more classic subchondral cyst. And here, a very degenerative femoral head where you can see these cyst-like changes, and you can see this solid-like material. And again, this is more like a gelatinous material that can liquefy, but often it's this more dense myxoid gel-like material that fills them. Here, again, subchondral degenerative cystic change, a very arthritic hip, where you can see these cyst-like changes. And this one, of course, had liquefied with a nice, almost glistening like pseudo margin, epithelial margin within it. Here's another example of a subchondral degenerative cyst. In this case, MR very nicely showing the high signal intensity. You get the feeling of a little sclerotic margin, and notice the edema-like change in the base of the bone adjacent to it. And here, really a very large subchondral degenerative cyst in this very ugly knee, and you can see the well-defined sclerotic margin, the associated degenerative changes within the joint, and of course the MR imaging showing that somewhat complex fluid-like signal. You can see a little edema adjacent to it, and of course following the administration of contrast, there's a little enhancement to the wall, but the lesion itself shows no solid tissue. And this is a very nice example of the subchondral degenerative cystic change that's very long-standing, had it become truly cyst-like in its appearance. Two additional cases. This in a young patient, and you'll often, you may remember the term intraosseous ganglion. And that term, as best as I can come up with talking to the people at the AFIP in orthopedic pathology many years ago, was that they found these lesions within younger people adjacent to the articular surface, but they had no degenerative change on radiograph. So rather than call it a degenerative cyst, they called it an intraosseous ganglion because they're histologically identical. And at least at that time, and I don't know if the genetic studies have shown anything different since that time, but histologically, subchondral degenerative cyst and an intraosseous ganglion were virtually identical. And so they're not histologically distinct, and hence that term is a little artificial, particularly in terms now of the new pathogenesis of how these lesions are. And here another one that was taken in surgery as a possible giant cell tumor. So, subchondral degenerative cysts, when do I worry? Well, I worry when they're not subchondral. I worry when they don't show an indolent radiographic appearance, and I worry when there's solid portions within it that show enhancement. So subchondral cysts, extremely common, not a true cyst, and usually quite small, as we talked about, and usually not a diagnostic problem. The last lesion that's an incidental that I wanted to talk about was just intraosseous lipoma. Initially, they were considered rare, but in reality with MR, we see them with fair frequency. Most often seen in middle age, and in the classic sense, were reported to have minor aching pain in up to 65%, but in reality, I think most are asymptomatic. We see them both in the long and flat bones particularly in the pelvis, and the long bones more commonly in the lower than the upper extremity. On imaging, when we see them in the long bones, geographic lytic lesions, typically with a sclerotic margin, but not invariably so. Expansile remodeling is seen in about 60 to 80%. More classically, towards the end of the bone, that is the metaphysis or the epiphyseal area, they can have involutional change, classically described as cyst-like changes or calcification and sometimes ossification. Now, much of what we know about intraosseous cysts or intraosseous lipomas came from Milgram's work in the 1980s, where he talked about three types. Type 1 was all fat. Type 2 we call partly necrotic, with some involutional change, typically with calcification. And type 3, which he said were mostly necrotic, where it can be hard to see the fat, but they had extensive reactive bone and cyst formation. But the point being, they can either be all fat or they can have involutional changes of varying amounts. This is an intraosseous lipoma. Notice the sclerotic margin. Notice the areas of ossification within it, all quite common features. And when we see scintigraphy on these, they usually show violently increased tracer accumulation. Now, how could I make this diagnosis? Well, usually I make it on MR, although when I see a benign appearing lesion with some ossification within it, particularly towards the end of bone, I always consider a benign fibroosseous lesion, and I use that term because that's how they were classified in the AFIP, under that fibroosseous category. And I think of an intraosseous lipoma in that differential. And here, the T1 weighted image, you can see the fat, but you might say, hey, wait a minute, that fat is awful dirty in the middle. Why is that? Well, that's the areas of involutional change where that fat will change its signal intensity, again, secondary to mineralization, calcification, ossification, as well as cyst formation. Here is a patient being evaluated for his degenerative arthritis of the hip, had this radiograph on the right 8 years earlier that didn't show that lytic lesion. This was certainly concerned. MR was done, which showed it was completely filled with fat. The diagnosis of an intraosseous lipoma made since he was going to surgery to get his hip done, that was confirmed histologically an intraosseous lipoma. Here, a patient being evaluated for myeloma had this lytic lesion within the distal shaft of the humerus. MR nicely shows the increased adipose tissue, and of course, we see that lytic lesion because of the scalloping of the cortex secondary to the fat within the medullary canal, that increased fat secondary to an intraosseous lipoma. And we would all make the diagnosis of an intraosseous lipoma through this anterior process of the calcaneus with this central cyst, very characteristic, and you'll see the beautiful fat surrounding it. And a T2 weighted image, quite characteristic. Now, if I showed you this lesion within the distal femur, what would you call that? Well, take a look at that lesion, and then look at that lesion, and they look awful similar. And if we take a look at the MR of that lesion, you can see the central cyst with a thin sclerotic margin within a larger lesion that's filled with fat. Now, we can see that very nicely on the MR with that central cyst with its calcific margin, and of course within a larger fatty lesion, and the corresponding T2 image showing the nature of that central cyst. And of course, just one more intraosseous lipoma with this central area of dense ossification, and you can see the fat and the periphery. All these intraosseous lipomas. Now, one of the things that I get a lot of consults for from my body colleagues are lesions such as this within the pelvis. And I can say that over the years I've probably biopsied about a half a dozen of these. And more typically, rather than a diagnosis, I get a list of histologic features. We see fat, we see bone, which sometimes is called ischemic ossification, and it can be called even an infarct by those not familiar with the radiologic appearance, but I would contend that these are just intraosseous lipomas with areas of involutional change, in this case, ossification centrally. And we see this, at least modest frequency within the pelvis, and I think very characteristic. And again, you can see the ossification within. So intraosseous lipomas, when do I worry? The answer is virtually never. When I see the fat within it, that's what it is. And you might say, well, wait a minute, liposarcomas metastasize to bone, and they do, but not well differentiated liposarcomas. It's always the higher grade, and when it's heterogeneous, it's the higher grade component that metastasizes to bone. And so while there may be some rare cases, they must be exceedingly rare, and I'm sure they may exist, but I have still yet to see one described. So I really virtually never worry when I see fat within the lesion. So intraosseous lipoma, not an uncommon incidental finding, usually towards the end of the bone, through metastasis or epiphyseal, frequent calcifications, and associated involutional changes, not uncommon at all. So these are lesions we talked about. Incidental MSK lesions may simulate more significant disease, although I do think close attention to the imaging features usually will allow an accurate